Up next, we have David Eberts, and senior author is Benjamin Colivard from Case Western in Cleveland, Ohio, presenting on the use of direct oral anticoagulants over warfarin improves survival and patency in infra-geniculate bypasses with vein conduit compared to prosthetic.
Hello, my name is David Eberts, general surgery resident out of Case Western. We're talking about the use of DOACs over warfarin for infra-geniculate bypasses and the differences between prosthetic and vein bypasses. No disclosures. As we all know, infra-geniculate bypasses have a patency rate of about 40 to 88% to 1 year, and there's been a lot of talk recently about the optimal management post-operative in terms of antiplatelet and potential anticoagulation medications. In 2017 was probably the first big VQI data that showed that anticoagulation might not have an effect on primary patency, but it did with secondary patency in prosthetic conduits. It's become more common for threatened bypasses, whether that's prosthetic, those with poor runoff, or coagulopathies, to be sent home on new anticoagulation. Some work that we did previously showed that DOACs do have improved outcomes in patients receiving femoral bypasses, regardless of conduit. And even more recently, just in 2022, a group out of Colorado utilized the Voyager data and showed that adding the Xarelto PAD dosing to those bypasses, regardless of conduit, did show decrease major adverse limb events. The goal of this talk and this study was then to see, does that difference really exist the same for both the vein and prosthetic bypasses? And we wanted to look at that within the VQI database separately from the Voyager database. This was a retrospective cohort univariate and multivariate analysis. We overall had 2 cohorts, both vein and prosthetic, and then 2 subcohorts within each, those sent home on a DOAC or a warfarin. Outcomes, we looked at survival, patency, amputation-free survival, and freedom from Mayo. Within the VQA database, we looked at all bypasses starting in 2007, which is really the first time people started reporting DOACs within the VQI database. And in that time span, we saw over 57,000 bypasses that were reported. Our inclusion criteria were anyone doing bypasses on patients that were anticoagulation naive, those that did not have any pre-op arrhythmias, and those that had a femoral to below knee bypass. We excluded anyone with acute limb ischemia, as that's a really separate entity, so this was purely aneurysmal and occlusive disease, and anyone that had bilateral procedures. From this, we had a patient population of 2,709 patients, and almost a near equal split between vein and prosthetic conduits, 53 and 46%. Looking at the demographics for our vein conduits, the warfarin group, there was about 2/3 patients sent home on warfarin, as opposed to about 1/3 sent on DOAC. And in the warfarin group, there was an increased association with Caucasian groups, Medicaid and Medicare insurance patients, as well as dialysis dependent. In the DOAC group, not surprisingly, there was an increased prevalence of private insurance, but something that was surprising was there's an increased amount of nursing home or homeless patients that were sent home on DOACs. On the opposite side, looking at prosthetic bypasses, there was, again, you'll see at the top right, the warfarin group, about 2/3 were sent home on warfarin as opposed to 1/3 on DOAC, so the 2 groups are really pretty mirrored. Again, warfarin group had more Medicaid, Medicare insurance. There was also increased amount of hypertension. And in the DOAC group for the prosthetic conduits, again, increased private insurance and nursing home or homeless population. But there was also increased prevalence of those on pre-op dual antiplatelets and those done in the preoperative, in the elective setting. So separating these results based off of just vein first, overall survival showed no statistical significance out to 2 years based off of warfarin in blue and DOAC in red. When looking at some of our more secondary outcomes, such as primary patency and amputation-free survival, there was an improved outcome for vein sent home on DOAC in red, there out to 2 years. There wasn't any difference we saw in male. Then when we look at the prosthetics, going out to 2 years, we did see an improved overall survival. Out to 2 years, that was significant. And for all 3 other outcomes, including male this time, prosthetics had an improved primary patency, amputation-free survival, and freedom from male out to 2 years when discharged on DOACs. But the real money kind of separates the 2 groups here with our multivariate Cox analysis. The table on the right up top shows vein. Nothing is bolded because none of the outcomes showed any significance in terms of hazard ratio when utilizing all those different demographics. However, with prosthetic bypasses, all 4 outcomes had decreased hazard ratio, therefore decreased risk of mortality, loss of patency, risk of amputation, and risk of mail. As we all know, with VQI data, there are a lot of limitations, as we've talked about multiple times here today already. It's retrospective. There is some heterogeneity that exists between these groups. We try to control it and try to get a really consistent population between the 2 groups. The other hard thing with VQI data is the actual DOAC used is not always stated. Sometimes it'll say Xarelto versus Eliquis, but not always, as well as it never tracks the dosage or the long-term adherence to it, which are very important things to know. As well as the complications are not seen in here, so we cannot look at bleeding risk or other issues seen with DOACs. From this, we know that DOACs are being used more frequently for our infra-geniculate bypasses. This study shows that DOACs do have improved outcomes compared to warfarin, especially for the prosthetic group. And it's suggesting that for anyone who you think is a threatened bypass, especially prosthetic, they should go home on a DOAC. I think this adds overall to the growing body of evidence about DOACs versus warfarin, and especially as more and more people are talking about the Xarelto PAD dosing, this adds to the evidence that this is a supportive and protective measure that can help protect our bypasses. And as stated, it doesn't really show the differences in terms of dosing, but this may add a little bit different thing than the Voyager data, which shows no difference based on conduit. Our study here shows that vein doesn't really have a difference, and if your patient might benefit more from warfarin over DOAC or have an increased bleeding risk, that it can be safe. However, prosthetic is where the real money is in terms of sending someone home on a DOAC. Thank you so much. Happy to take any questions.
Do you think if you were able to look at the dosing, do you think it's going to be full DOAC dosing, or do you think it's going to be that lower dose? I mean, do you think it's going to make a difference ultimately if you were able to capture that data?
I think it will be a difference, especially when we looked at, we don't have it in here, but a histogram of when DOAC started to be used more and more in the VQI data. I bet the early times in like 2010 is probably full dosing, and I'm sure in the past 5 years is when we'll really see a lot of the half 2.5 milligram dosing. And I would wager that it's going to be protective with both, but if the 2.5 is just as protective, then there's no reason not to go for that lower dosing.
Hey, Robert from Missouri. Would you recommend getting factor Xa levels at day 10 just to make sure that this is working before you really committed to this for long-term use?
I think that's a good question about whether or not tracking how well, not just whether or not patients are following up on it, but are they responding to it? I'm not too sure on the efficacy of how well the 10A really responds to it, and I think we might have to make some kind of blanket statements, just like people we're sending home on Plavix dosing. We're not testing everyone whether or not they're a Plavix responder, even though that's a huge subset of people that are. So I'd have to look to see how much might not have response to factor 10A with Xarelto, but if it's a huge one, then maybe we should.
Hi, Elena Quiroga from Seattle. Very nice presentation. I have a question. In one of the busy tables that you show, it says that white patients, if I read right, were either in warfarin or DOACs in a 66%, with only 17% of black patients were placed in any type of anticoagulation. Can you comment on this finding? And if you are reporting race, can you tell me how you're going to address this in the manuscript?
And to be clear, you're asking whether or not patients who were Caucasian were more often, were white, were more often to be sent home on anticoagulation?
No, that's you already showed. 66% of patients that were white were sent in some kind of anticoagulation. 17 that have been published multiple times in VQI, that there is a difference in how the patients get discharged home depending on your race. The issue that how are we moving past reporting the difference, and what are you going to do? How are you going to address this discrepancy or disparity in your manuscript?
Gotcha.
And if not, why are you reporting race?
Right. We included race only because it's something that's brought up commonly, and between the vein and prosthetic group, both did have increased for warfarin being sent home for Caucasian. I'm not sure why, whether that's a provider unknown preference, and I don't have a really great answer, unfortunately, to how to fix that error in the future, but I think a more deeper analysis could be seen. Is there an actual racial difference in terms of response to the different anticoagulations?
Yeah, it would be nice to look at a little of the bias in the prescribing. There's a lot of literature on that, and try to address us in the manuscript, because we all need to be aware that this is happening every day in every single hospital.
Absolutely. Thank you.
take one more question.
Sure. I really enjoyed that. I trying to figure out how DOACs, to incorporate them, and I think this will be helpful. One of the questions I have is with the VQI data. Obviously, it's very robust. Things to consider with bypass analyses, the differences between CLI and claudicants, as well as first time and redo bypasses, because a lot of times, and there's some way to figure that out in VQI, whether it's the second procedure for that patient in the data set and/or they have history variables that flag them for previous bypasses, because we know that those who fail are going to be at higher risk for failing again. Those are also the ones that maybe be put on anticoagulants more or different ones, and sort of curious how you worked through that. Thank you.
I would say definitely it's a great question for the indication, whether it's claudication versus rest pain or tissue loss. In our prior work, we did see that those with tissue loss and especially rest pain had the greatest effect of having a protective benefit with the DOAC, and we'd have to see, and I probably will include it in this manuscript, does that hold true for when we separate it based off of vein and prosthetic conduits? And I'm guessing it'll be the same, but we'll have to see. It might be just for the prosthetic.
Great, nice presentation. Thank you.
Thank you.
Thank you.